post-COVID syndrome, I think August 2020 first guideline state. India, one of the earliest guidelines on post-COVID syndrome was by Kerala. But after that, the definitions and all have changed a lot. And all of us have seen, experienced multitude of manifestations of post-COVID syndrome and treated hundreds of cases of post-COVID syndrome. The current context of Omicron, we know that majority of the patients are having, say, mild infection. So they're not requiring hospitalization. Only 3% require hospitalization, of which only, say, 0.8% require oxygen. And, say, 0.4 is the other patients who require ICU care. But post-COVID syndrome can occur irrespective of the severity of the symptoms. So really, we don't know whether, even these mild infections due to Omicron can also translate to the post-COVID syndromes in the same extent. From the, we are having a big cohort of healthcare workers who got infected in the January itself, probably due to Omicron. So around 940 healthcare workers got infected in January itself. And at least some of them are coming with the classical post-COVID syndromes that we have seen with the previous variants, like, say, Delta or the previous D614G, etc. So with this, I will go to the topic per se, that is an approach to the post-COVID syndromes. The title slide I have not changed. The yellow road is actually shows that now, at least for some patients, the road to recovery is going to be prolonged following the acute COVID-19 infection. So basically, the background we know, most patients who suffer from COVID-19 fully recover, but some, that is 10 to 20%, remain with long-term effects on several body systems, including the pulmonary, cardiovascular, nervous system, as well as some may go on to develop psychological problems as well. These effects appear to occur irrespective of the initial severity of infection and tend to occur more frequently in women, middle-aged, and in those with more symptoms initially. So this is important. This is irrespective of the initial severity of infection, you can have these post-COVID manifestations. And studies have shown that it is more commonly seen in women, middle-aged, and in those who present with more symptoms initially. That is understandable. So this is actually a natural history of COVID-19. We know that following a mild infection, the time taken to recover maybe around, say, is around 14 days. But then with the Omicron being a milder variant, so the time taken to recovery may be around 7 to 10 days. But with severe disease, previously also the time taken to recover was around, say, 2 to 6 weeks. And we know that the RAT positivity or negativity does not mean that the process has come to an end. Because COVID-19 is about the viral replication followed by the dysregulated immune response. So irrespective of whether you have become antigen negative, or you cannot say that the disease process has come to an end, because the virus has set in motion a set of immunological responses. But probably these immunological responses are the reason for the post-COVID syndrome. So in short, it is referred to as the domino effect. That is, in the initial week or so, you are having the phase of viral replication. And then in susceptible population, this can lead to immune dysregulation, induced susceptible endotheliitis, because the ACE2 receptors are present in endothelium as well. So this can lead to endotheliitis, and this can activate the coagulation cascade, which can lead to micro as well as macrovascular thrombosis. And Bindu Mohan Madam did allude to the occurrence of myocardial infarctions, of venous thrombosis, the stroke syndromes, etc. And that is because of this aspect, that is endotheliitis and activation of the coagulation cascade in susceptible population. And then the certain studies have shown that in the phase of viral replication, the next 2 to 3 weeks, a lot of diverse functional autoantibodies are produced in the susceptible population. It is this because of these autoantibodies that some persons develop this post-COVID syndromes, like excessive fatigability and all. The initial definition, first of all, we know the term was long COVID. It was actually coined by some patients in WhatsApp groups, etc. So that is a long COVID is the term coined by patients. And then came the NICE definition. So which actually in December 2020, they classified these manifestations into acute COVID-19. They said that whatever signs and symptoms which occur within, say, 1 month of symptom onset is acute COVID-19. So suppose a patient is COVID positive today, and after 2 weeks he's coming with, say, severe headache or, say, polyarthritis, etc. You cannot term it as actually post-COVID. It is actually a part of acute COVID-19 itself. Then the signs and symptoms which persist for 1 to 3 months is referred to as ongoing symptomatic COVID-19. And post-COVID syndrome is the term which is used only when the symptoms and signs are persisting for more than 3 months from the initial symptom onset. So this thing, there is what happens after 1 month is again divided into acute and chronic post-COVID thing. So 1 to 3 months you can say as acute post-COVID, and say after 3 months you can say as chronic post-COVID syndrome. So this is basically the timeline. So you can see that initially there is a viral replication, and then the immunological mechanisms are set into motion, and patients can have the persistence of symptoms or appearance of new symptoms in the described time frame. So this the new symptoms could be in different organ systems. The patients can have excessive fatigability, decline in quality of life, myalgias, muscular weakness, arthralgia, arthritis, then obviously the exertional dyspnea, anxiety, depression, post-traumatic disorder, etc., palpitation, chest pain, thromboembolism, etc. And then, say, after the NICE definition, which came in December 2020, WHO came with this case definition of the post-COVID syndrome in October 2021. That is, say, approximately around, say, 1.5 years after the first case of COVID-19, WHO came with a clinical case definition for post-COVID syndrome. So WHO definition goes like this: post-COVID condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last at least for 2 months. And this symptom should not be explained by an alternative diagnosis. The common symptoms include fatigability, shortness of breath, and cognitive decline, but can also include other complaints which affect the general everyday functioning of the individual. Symptoms could be new onset symptoms following initial recovery from acute COVID-19 episode, or could be symptoms which are persisting from the initial illness. Symptoms may also fluctuate or lapse over time, and this is a definition for adults. A separate definition should be made for the children. That is what the WHO said. So they are focusing only on 3 symptoms, that is fatigability, exertional dyspnea, and cognitive dysfunction. But if you go through their document, so they had a modified Delphi's sort of definition, and in that around 35 symptoms have been described as part of this post-COVID symptomatology, of which the most commonest ones are excessive fatigability, shortness of breath, and cognitive dysfunction. So as Madam said, since ACE2 receptor is present in multiple organ systems, and it's not only there in the type 2 pneumocytes in the lung, it is present in the endothelium, it is present in the myocardium, it is present in the blood-brain barrier, it is present in the hepatobiliary system, the renal tubular cells, the pancreatic beta cells, etc. So you can have all sorts of manifestations, and this can manifest after the phase of viral replication itself. Because of activation of coagulation cascade, patients can present with venous or arterial thromboembolism. The patient is having, say, catheters, like, say, the dialysis catheters, etc. We have seen many cases where the dialysis catheter-related thrombosis has occurred. As far as the heart is concerned, you can have myocarditis, cardiomyopathy, stress cardiomyopathy, cardiomyopathy, cardiogenic shock, acute coronary syndromes, etc. So endocrine is the most important thing, because we know that along with COVID-19, you can have new onset of diabetes mellitus, as well as the worsening of glycemic control. It's very, very important, and probably for patients, it may take weeks or months for them to regain the glycemic control. So dermatological manifestations, in the previous discussion with Kollam 2 days back, someone asked about urticaria. So this arterial vasculitis can occur in the post-COVID phase as well. That's after acute infection. Also, you can have manifestations in the skin. It could be in the form of arterial rash, it could be in the form of a morbilliform or a maculopapular rash. It could be papulovesicular rash, livido-reticularis, it could be purpuric rash, or the acre lesions, chilblain-like lesions. So the skin manifestations are also very common. When it goes to the brain, you can have cognitive dysfunction, you can have the stroke syndromes, you can have the demyelination, anosmia, parosmia, all these things can occur. In the renal, they have the classical thing known as the COVID-associated nephropathy. You can have transaminitis. In certain cases, you can have this inflammatory diarrhea persisting for a long period of time. So this is actually, a study which was done initially in our healthcare worker cohort, where they had excessive fatigability in around 60%, exertional dyspnea in 30%, altered sleep rhythm in 24%, excessive hair loss in 20%, myalgia in 15%, headache in 15%, multiple joint pains in 10%, and brain fogging, which is otherwise referred to as executive dysfunction 10%, anxiety in 10%, and depression 2%. But no, we did this study when the initial definition said that no, any symptom persisting after 21 days should be considered as acute post-COVID syndrome. So the study looked at the symptoms persisting after 21 days from the symptom onset. Now, this is the largest study. No, they followed up the patients with who required this thing. They divided the patients into 3 groups: patients who did not require oxygen, who required oxygen, and patients who required this NIV or a ventilator. This study was done in Wuhan. They followed up the patients for 6 months, and they found that even after 6 months, 63% had fatigability. Sleep disturbance was there in 26%, hair loss in 22%. That is what Bindu madam referred to as the telogen effluvium. Then anosmia, parosmia in 11%, palpitations in 9%, arthralgia in 9%. Important, there are people who are not regained their sense of smell even after 9 months. And there are certain unfortunate individuals who are developed parosmia following the initial anosmia. So this is the graph which shows that this is a study from Wuhan. So after 6 months, it's a follow-up study on say 1,700 patients, and even after 6 months, they had the persistence of these symptoms. The commonest one is obviously the excessive fatigability, and this is with regard to what happened to their lungs. After 6 months, as I said, they had divided the patients into 3 groups. The first group looked at patients who did not require supplemental oxygen while in hospital. The second group who required supplemental oxygen, and third was the group which required high flow nasal oxygen, NIV, or mechanical ventilation. And you can see that diffusion capacity was restricted maximally after 6 months in the group which required NIV or ventilation. And the CT showed ground glass opacities. So you can see the most interesting aspect is in actually the 3 groups, the presence of ground glass opacities after 6 months is almost the same: 40%, 48%, and 45%. The irregular lines, that is what you term as fibrosis, was present in say 25% cases of patients who required invasive mechanical ventilation or NIV. So when you're having patient is coming to you in the post-COVID clinic, so what all things that you should be looking for? In all the systems, the patients can have manifestations. In the cardiovascular system, patient can have palpitation, which could be due to myocarditis, cardiomyopathy, or cardiac failure. The respiratory system, they can present lung fibrosis, pulmonary artery hypertension, pulmonary embolism. Nervous system, they can have multitude of symptoms: anosmia, stroke syndrome, short-term memory loss, reduced attention span, confusion, poor quality of sleep, cognitive impairment, and cognitive blunting, which is referred to as the brain fogging. Then the mental health aspect is a big thing, and Bindu Mohan madam did say that is the mental health the problems due to COVID per se, or is it due to hospitalization, is a big question that needs to be answered. So anxiety, depression, post-traumatic stress disorder, and sleep disturbance should be addressed. And musculoskeletal system is also not spared. Patients can have polyarthralgia, arthritis, myalgia, excessive fatigability, and chronic fatigue syndrome. So we know chronic fatigue syndrome is almost synonymous with the Epstein-Barr virus infection. So this can occur in the COVID as well. And this is referred, the scientific name for the chronic fatigue syndrome now is the systemic exercise intolerance syndrome, where the following physical exertion, mental exertion, or emotional exertion, you can have excessive fatigability. And what are the mechanisms for the post-COVID syndrome? So these are the 7 potential mechanisms which have been, which are thought to play a role in the genesis of the post-COVID syndromes. One is the persistence of a low-level inflammatory or a hyper-inflammatory milieu. So that is the most, the explanation which is brought by majority of the clinicians. The presence of a lower level of inflammation which is going on in the patients. Second is immune dysregulation or autoimmune etiology, and multiple studies have shown that, especially in young females with multiple symptoms after recovery, it is due to the presence of diverse functional autoantibodies. Third is the patient is having DVT or something like that, is due to the activation of the coagulation cascade. So in certain patients, the viral persistence and the body's response to that, and viral toxicity could be the reason for the post-COVID syndromes. Autonomic dysfunction is very, very important, especially in young females. They complain of a sudden onset of palpitation and sweating, etc. This is referred to as, even say 1 month after recovery, and they initially had only mild infection. So they have sudden sweating, they have sudden palpitation, etc. This is referred to as postural orthostatic tachycardia syndrome, SPOTS. And we are seeing this more and more in females. And the reason is that the dorsal root ganglia also have this ACE2 receptor, And definitely the virus will go and bind with the ACE2 receptor present, the DRG. This can lead to this autoimmune manifestations. And then endocrine metabolic axis is also affected and maladaptation of the ACE2 pathway as well. So now there is an 8 mechanism. So it is also being postulated because of COVID-19 per se, or because of the immunosuppressants that we are using like steroids or tocilizumab, etc. So there could be reactivation of the latently this Epstein-Barr virus or CMV, etc. And probably the excessive fatiguability, etc. also could be due to these viral infections, the reactivation of EBV, CMV, etc. That is another mechanism. And this was a recent article, so this published around, say, 1 week back, which actually the most interesting, the post-COVID syndromes are the things which occur in the brain. That is, the executive dysfunction, the impairment in attention, impairment in concentration, the impairment, the speed of information processing, impairment of short-term memory, etc., which are occurring even in patients who had only mild COVID-19. We have seen numerous patients, even the postgraduate students, etc., complaining of this brain fogging. And now they say that the long COVID cognitive syndrome shares many features with the syndrome of cancer therapy related cognitive impairment, what is referred to as the chemo fog. Okay, and they have found that the CSF cytokine CCL11 is persistently elevated in mice as well as humans with neurocognitive dysfunction post-COVID. And the neuroinflammation, particularly the microglial reactivity and consequent dysregulation of hippocampal neurogenesis and oligodendrocyte lineage cells are the reason for this chemo fog. And they also postulate that this is the reason for the brain fogging, which is occurring in post-COVID syndrome as well. Now, whatever we have discussed till now, the multitude of manifestations of post-COVID syndrome can be grouped under 4 categories. One is the classical post-critical illness syndrome. That is, any patient who gets into the ICU, they have their own problems, like they have the critical illness, neuropathy, critical illness, myopathy, ventilator-associated diaphragmatic dysfunction, etc. They have nutritional imbalance, etc. And their road to recovery is definitely going to be a long one. So it may not be related to COVID per se. Any patient in the ICU due to any etiology, they can develop this classical post-critical illness syndrome, and COVID-19 is no exception. The second is a post-viral fatigue syndrome, which also is not unique to COVID-19. This, we have seen in dengue shock syndrome, Epstein-Barr virus, etc. Third is the lasting organ damage. That is, the patient is having severe pneumonia and the subset can progress to fibrosis and may take time to recover. Can occur with myocarditis also. Patients progress into cardiomyopathy and time to recovery maybe, say, weeks or months together. The most interesting aspect is the fluctuating symptoms with slow recovery. That's seen even in patients with mild COVID-19. That is, the triggering of migraine, triggering of polyarthritis, urticarial rashes. Some patients can have developed this anaphylactic reactions, etc., following COVID-19, etc. Now, so how long are these symptoms going to persist? That is the question that we usually face. The patient is saying fatigability, so will I be fine within a week or 1 month, etc. So that depends on the individual susceptibility. So data from the initial SARS-CoV-1 shows that around 40% of the people recovering from SARS still had chronic fatigue symptoms 3.5 years after being diagnosed. I don't think that this is going to be the number with COVID-19 per se, because for majority, the fatigue is improving within weeks or months. Now, what is the natural history of the post-COVID fibrosis? So something which is referred to as the post-COVID ILD. So in the subset of patients who develop severe pneumonia, it's say 1%. So they can, in majority of them, the fibrosis will improve by itself. That is the most common manifestations. It remains static, which is a less common manifestation. In around 5%. So despite the oxygen therapy or despite the adequate use of steroids, the fibrosis can progress. And it is in this group that probably the antifibrotic drugs like pirfenidone, nintedanib, etc. may have a role. Otherwise, these antifibrotic drugs do not have a role in the treatment of the post-COVID ILD in the COVID setting. So we need to identify those patients despite steroids are progressing, the fibrosis is progressing. And probably in that group, we need to try this antifibrotic drugs. Now, this is the most interesting thing. This is a study which was published in 2020. That is, this was done in USA. They studied it in the college athletes who had only some mild symptoms. So there was an asymptomatic group and a group with mild symptoms only. And they did what is referred to as the cardiac NMR, nuclear magnetic resonance imaging of the heart was done, and a spectral tracing echo was done. And they identified that even in patients with no symptoms, in the asymptomatic group, myopericardial involvement was there in 7%. And the symptomatic one, as mild symptoms, the myocardial involvement was 16%. So this shows that, so in around 16% mild symptoms also, a subtle myocarditis was there. So this, when we are doing our echo, it may not be evident, because the usual echo can't pick up this subtle myocarditis. This was picked up only by this cardiac NMR as well as speckle tracing echocardiography. The significance is probably for people like us, it may not be really significant, but for athletes, whose level of exertion is very high, this subtle myocarditis can turn out to be life-threatening. So we have seen many cases where, after apparent recovery in the second week or third week, they're doing strenuous exercise and they're collapsing and dying. Probably the reason is the subtle myocarditis that these patients are having. And one very, very important aspect that we need to keep in mind is the multisystem inflammatory syndrome in children and multisystem inflammatory syndrome in adults. We know that this multisystem inflammatory syndrome in children will not be missed, because all our pediatricians they know about the clinical multitude of manifestations of MISC. They are picked up, and the mortality in Kerala in MISC is actually very, very low. But then after 12 years, these patients will be presenting to the physicians, and probably, since we have enough and more DDs for such a manifestations, MISA may not be picked up. So what is actually the pathophysiology or natural history of MISA? The trigger will be a mild COVID-19 infection. So it could be a asymptomatic infection or a mildly symptomatic one, and probably that could be missed. And after 3 weeks or so, because of the immune dysregulation, that is the mild the COVID-19 infection will act as a super antigen. And this will lead to the cytokine release, the T helper cell activation, as well as the plasma cells producing more of antibodies, hyperimmune response, and by around the third week, usually by around third week, the patient can present with high grade of fever with dyspnea, which is not due to the lung involvement, but is due to myocarditis. Usually the patients will present with acute abdominal pain and diarrhea. This abdominal pain is usually due to this mesenteric adenitis, ileitis, colitis, etc. Patients can have the acute kidney injury, pericholecystic edema, meningeal irritation, etc. And the patients, the conjunctiva might be congested, rash, etc. may be there. So in such a setting, a patient is presenting to you like that, the thing you need to ask is the past history of a mild COVID-19. Probably if they are asymptomatic, they may not be aware of such a diagnosis. Ask about history of COVID-19 in the family in the last 3 months or so. Or so such a history you need to ask. We'll take you through one case. So this was the first case that came to us in October 2020. That's a 23-year-old male person with fever, fatigability of 3 days duration. Patient had a pseudohepatorenal syndrome. There is acute injury along with transaminitis was present. Patient had myocarditis, hypotension was there on presentation. SpO2 was 95%, and COVID RAT as well as PCR was negative. And if you look at the investigations, total count was very much elevated with a lymphocytopenia, or you can say neutrophilia. Thrombocytopenia was there, CRP was elevated, PROP-T elevated, PRO-BNP elevated. So in such situations, you can think of many DDs, so which include the tropical fever syndrome, because any patient who is presenting like this to us with leukocytosis, neutrophilia, hypotension, myocarditis, transaminitis, kidney injury, it could be wheel syndrome, or it could be strep typhus infection like that. So tropical fever syndrome has to be ruled out. And you know that within 7 days, it is very, lepto IgM as well as strep IgM will be negative. So you need to look at the lepto PCR. So that is a major challenge that we need to face in such a situation. Is it septic shock? No, it is possible, but then in a youngster without any comorbidities, without a foci of infection, them presenting with septic shock is a bit unlikely. Infective endocarditis echo was normal. And can it be MISA? If you looked at the other parameters, the inflammatory markers were very much elevated. That's D-dimer was more than 10, ferritin more than 10,000, CRP was very much elevated, IL-6 was very much elevated, and procal was more than 100. So procal is 100, it does not mean that the patient is having a bacterial sepsis, because procal is an inflammatory marker as well. So the basic thing I would like to convey is that if you are having such a patient, that is a patient who is coming to you with a young patient, probably young patients who are present to you in hypotension and with the multiple organ involvement. So the first thing that will come to your mind is going to be, say, leptospirosis, but you need to keep multi-system inflammatory syndrome in adults as also one of the DDs, because the treatment for MISA is going to be loading the patient or pulsing the patient with media prednisolone, which is going to be like life-saving. All of you are aware of this, the case definition of MISA, which is there in our, the guidelines, the clinical protocol. Please do go through the working case definition of MISA. So the rule of the thumb will be that any patient who is presenting, any patient who is presenting with shock, and the patient is having myocarditis with multiple organ involvement, think about the MISA as one of the DDs. This is a recent case. You can see that. So the mimicker of a gut perforation, etc., could be acute abdomen, could be the MISA. So this patient was a 19-year-old girl who presented to our casualty with acute abdominal pain and diarrhea, fever, and hypotension with multiple organ involvement. And then ultrasound showed that it's probably a perforated appendix, and then an emergency lab was done because the patient was in shock. And you can see that the terminal ileum was thickened, mesenteric adenitis was there. There was no perforated appendix. So, and then the patient went into hypoxia. It was because of myocarditis. So you're having an acute abdomen-like presentation. It's just a negative lab. You're having acute kidney injury. You're having, say, myocarditis, and because of myocarditis, patient went into hypoxia, had to be ventilated, etc. And then we came at the diagnosis, so probably it could be MISA as well. And the patient was loaded on media prednisolone, and patient went home after 5 days. And another important manifestations we have discussed is actually the presence of patients with venous as well as arterial thrombosis. Patients can present you with venous sinus thrombosis, CRVO, CRAO. Patient can present with all sorts of gangrene, etc. So we should be knowing about, should be keeping this thing in mind. Patients can have micro as well as macrovascular thrombosis, and this can occur. So within, say, 1 to 2 months of diagnosis of COVID-19 as well. So the answer to this, is it giving anticoagulation to everyone with COVID-19? No. So those patients who have been diagnosed with embolism or DVT during hospital stay definitely need 3 to 6 months of anticoagulation. That has to be there. But for those patients in whom we are giving anticoagulation prophylactically based on their oxygen saturation, who are the patients who require post-discharge thromboprophylaxis, has to be identified by calculating the modified VTE risk score. So if the score is more than or equal to 4, you give the patient apixaban or rivaroxaban for, say, 3 weeks or so. The score is more than 2 with the D-dimer more than 1,000 also, you give the post-discharge thromboprophylaxis. Another aspect is that in a patient who is presenting to you in the after discharge or after apparent recovery, need to keep in mind the possibility of the infection syndromes also, because in such a scenario, suppose the patient is coming to you with a catchy type of chest pain, say a dyspnea, a fever, etc., and the CT is showing nodular cavitatory lesions. And the first thing you should ask is the net immunosuppression that the patient required during the hospital stay. That is the steroids, the dose of steroids used, the duration, whether the patient was given tocilizumab or the JAK inhibitors, etc. You need to ask the net immunosuppression to which the patient was subjected during hospitalization. And based on that, for a nodular cavitatory lesion CT, the DDs will be a reactivation of tuberculosis. It could be COVID-associated pulmonary aspergillosis or a COVID-associated pulmonary mucormycosis. So we need to keep this in mind. Any patient who is coming with a nodular cavitatory lesion in the leg, think about these possibilities. And obviously, I'm not going to talk about rhino-orbitocerebral mucormycosis. So any patient who is complaining of severe facial pain with facial edema also, the post-COVID period, think about the possibility of a mucormycosis as well. Coming to treatment of the ongoing COVID syndromes. So most important aspect for them will be the rehabilitation, as pulmonary rehabilitation, nutritional rehabilitation, as well as psychosocial rehabilitation. Antifibrotics should be limited to those patients who are having progressive fibrosis despite the use of adequate dose of steroids. Anticoagulation, the indication and use we have discussed. If the patient is having cardiac failure, the patient should be treated for cardiac failure. For chronic fatigue syndrome, we don't have drugs per se for that, but then omega-3 fatty acid, vitamin D, vitamin E, etc. might help. Vitamin D only in those patients who are having hypovitaminosis D. For those patients with having neuralgic pain, so we are having patients who are presenting with some neuralgic pain syndromes as well, then for them treat for neuralgic pain like say pregabalin, gabapentin, etc. So the importance of nutrition rehabilitation, especially in those patients who had been in the ICU, there is to an extent catabolic muscle wasting, feeding difficulties, and frailty. So malnutrition seen around say 26 to 45%. So we need to assess the nutrition status, swallowing function, and the functional independence, and we need to come out with a nutritional rehabilitation plan for them. And one of the most important, the maximum loss which has occurred in the world due to COVID was with respect to the sleep. So there is a term known as COVID insomnia, and many patients may not be willing to take, say, solpidem, solpresh, or clonazepam, things like that. The most important thing is, rather than going for the pharmacological intervention right from the beginning, try to inculcate them the habit of sleep hygiene. So aim for at least 7 hours of sleep, exercise during daytime, avoid caffeine in the afternoon, avoid alcohol, avoid blue light exposure 1 hour prior to bedtime, aim to go to bed at the same time each night and avoid afternoon naps, etc. So now, what are the reversible causes of fatigability? So we try to think that all patients are having fatigability is a post-viral fatigability. It will take time. You give them vitamin supplements, etc., hoping that it might have some sort of placebo effect. But the most important thing is we need to identify the reversible causes of fatigability. So one is hypothyroidism. The most important thing is that we said that everything is an immune dysregulation. So patient may be having hypothyroidism, majority are taking L-throxine, etc. So they may be taking say 50 micrograms. And as part of this immune surge in COVID-19, the thyroiditis would have worsened and the requirement would have shot up to say 75 micrograms, etc. So excessive fatigability, reassess the thyroid function, probably need to optimize the dose of thyroxine that you are administering. Secondly is the hypoadrenalism. So it can occur in patients who have been on steroids, on withdrawal, so you can have secondary adrenal insufficiency. Otherwise, also you can have that. So you can do the fasting 8-time cortisol and see whether the patient is having secondary adrenal insufficiency. Hypovitaminosis D, if it is present, correcting it with vitamin D supplements will definitely help. Another interesting aspect is obstructive sleep apnea. So the patient is obese and you ask about the the snoring, etc. And suppose the patient is saying that we are having excessive daytime sleepiness after recovery from COVID-19. So you need to do the sleep study, because even in patients who have undergone sleep study in the past, so what we have seen is that because of muscle dysfunction which is occurring with COVID-19, the hypopnea index actually has worsened. So some patients might require CPAP, and with that the fatigability will come down. This worsening of obstructive sleep apnea with COVID-19. So what about, so patient is having a persisting fatigability for 3 to 4 months and also can I take vaccine? That is one important question that is being asked. So in the largest survey to date of vaccinated people with long COVID, 57% of respondents reported an overall improvement in their symptoms following vaccination, while 19% reported an overall deterioration. That means that if you're having excessive fatigability, etc., so if it is time to take the vaccine, you go for the vaccine shot. That's after 3 months. You go for that, and in all probability, you're likely to improve only. So that does not apply to patients who have developed and some immunological manifestations after vaccine. Them now going for the second dose, need to be very, very careful. And now coming to the system which has been put in place in the state over the last 1.5 years or so to address the post-COVID issues, we have a 3-tier system. So we have the first tier, we have the PHCs, FHCs, CHCs, and the second tier, the district hospitals, and the third tier, the general hospitals as well as medical college. So we have 35 symptoms which come under the post-COVID. So the aim in the PHC or FHC or in the e-Sanjeevani platform should be to identify those patients with red flag signs and to assess them and to refer them to higher centers for focused evaluation. So the red flag signs as far as post-COVID syndrome is concerned is, one is dyspnea, second is palpitation, third is chest pain, unilateral pedal edema, syncope. So if you take dyspnea, so it could be due to the pulmonary cause, it could be due to cardiological cause, or it could be due to pulmonary embolism as well. So we need to go for focused evaluation, identify the problem, address it. So if it is not possible at the PHC level, refer the patient to higher centers. So I think in the previous discussion, one question was with regard to can this arthritis, etc., occur following, say, vaccination? So the same question can be put in another way. Can this the immunological phenomenon occur following COVID-19 as a post-COVID syndrome? So we know of this, there is an entity known as Asia syndrome. Asia is autoimmune, auto-inflammatory syndrome induced by adjuvants. Okay, autoimmune, auto-inflammatory syndromes induced by adjuvants. So, but then if you are looking at the criteria, major criteria, they say that exposure to external stimulus, it need not be an adjuvant per se. It could be an infection, vaccine, or an adjuvant can lead to auto-inflammatory or autoimmune syndromes. Okay, so whatever we are actually talking about, say patients coming with polyarthritis, uveitis, etc. in the post-COVID period, all these things can be grouped together under the diagnosis of this Asia syndrome, whose major criteria. So in order to say that a patient is having Asia syndrome, you need to have two major or one major and two minor criteria. And what are the major criteria? It's very interesting. So myalgia, myositis, muscle weakness, arthralgia, chronic fatigue, unrefreshing sleep, neurological manifestations like demyelination, cognitive impairment, the presence of pyrexia, dry mouth, etc. The minor criteria, then the major includes biopsy as well. Minor criteria will be the appearance of autoantibodies. So the manifestations like irritable bowel syndrome, specific HLA. So this Asia syndrome is occurring only in a subset of patients with a particular HLA phenotype for whom an immune trigger in the form of a vaccine or an infection. So this COVID vaccine can be the trigger, or it could be the COVID infection per se. In a certain patients with certain HLA phenotypes, they can have a clustering of manifestations which actually mimics autoimmune manifestations. And that is why we say that one of the reasons for the post-COVID syndrome is the presence of diverse functional autoantibodies. So if you are able to put the patients into a particular category of an autoimmune syndrome, then the treatment for the same is steroids. It's very important thing. So thank you very much. As Bindu Madam said, no, the real the magnitude of post-COVID manifestations in this Omicron surge, we really don't know. And I think that our post-COVID clinics are already busy and is going to be busier. From our experience from the healthcare worker cohort, at least, I won't say that previously we used to have around say 10% post-COVID syndrome. We are dealing with mild healthcare workers are developing only mild COVID-19. Now I will say it is around say 2%, but then 2% of total number of Omicron cases is going to be huge. So that is why we need to streamline the function of all our post-COVID clinics. I'd like to thank NHM as well as Bindu Madam for this opportunity. Thank you.